Thank you very much, Margaret, for the kind introduction, and I think it's going to be a very interesting session. I'm going to kick off talking about long-acting products, actually novel products. I've slightly enlarged the scope of my discussion, and I also want to talk about some of the related issues because my talk is also in a session on access to haemophilia products, including opportunities and challenges, so I'll make some introductory comments. Clearly, we live in an exciting time when, based on recombinant technology, we're modifying structures of factor VIII and factor IX to improve on nature, to get products with longer half-lives, with reduced immunogenicity, and a whole host of products are under development. I think the focus has been very much on novel agents, but I don't think we should overlook the biosimilars, which are essentially copies of factor VIII and factor IX, because these, by introducing competition to conventional factor VIII products, will clearly help to spread the use of recombinant products. I think it's also important to emphasize that we've got used to, in the past, doing clinical trials on products which inevitably then get licensed. And we've seen several examples of new products not getting through for various reasons. I've been involved with a couple of those trials. For instance, Vitreptocog from Novo Nordisk was a Novo 7 analog with 3 amino acid sequences changed. And this change in 3 amino acids resulted in immunogenicity. So we've got to be vigilant and look out for new problems when we carry out clinical trials in these products. I think also we need to bear in mind the goal of haemophilia care, and as the previous president of WFH, Mark Skinner, said in his last plenary, the patient group would certainly feel that a factor VIII or IX trough level of 1% is wholly insufficient, to quote his words, and indeed we need to aim for higher levels, because only with higher levels can people with haemophilia really lead essentially normal lives. And of course, the treatment of haemophilia in that regard is very different from, say, diabetes, where we're aiming for a normal blood glucose level the whole time, and it's really the cost of the products at the moment that limits therapy. But a realistic goal, I think, is to move forward, again, quoting Mark Skinner's words, looking at trough levels of 3 to 5%. And clearly long-acting products can help us achieve this goal. But as someone who's actively involved in clinical trials of these products, I do worry about their affordability. And I think it's to the company representatives here in the audience that I would say, don't price them too high. I mean, we've seen, for instance, the price of recombinant factor 13, which has recently come out, really set at a ridiculous price compared to the plasma products, is €8 per unit. So I really would have to say that we need affordable products. And since this is also a session about access and opportunities, I would say that this is an opportunity for many countries in Europe to get involved in clinical trials, because this really is facilitating access to really exciting novel therapies. And actually, not only is it of benefit to the patients, but there are many countries involved now in clinical trials in Eastern Europe. And I would quote some figures from our last annual report of the UK Haemophilia Centre's Doctors Organisation, and that is in the last year, some 7 million units of factor VIII from clinical trials was used. Now, that's a saving of, at least a couple of million euros. And indeed, in the last year, 6% of factor IX usage in the UK was accounted for by investigational drugs. This is a great opportunity for people with difficulty with accessing products to get involved. And indeed, I also think, as someone actively involved in in developing programs in countries, I think there is an element of foot-in-the-door syndrome. I think if patients are established on a product, it does make it somewhat more easy to introduce it into regular clinical use afterwards. So with that in mind, I'm going to talk now about some clinical trials. I want to say right at the outset that I'm going to be talking about just some of the clinical trials in which I've been involved with in one way or another. But I want to emphasize that all the companies, the major companies you'll be aware of, are involved in clinical trials. So although I'm talking about Novo Nordisk's products, for instance, to start with, Bayer, Baxter, CSL Behring, Sobi, and Biogen IDEC, they're all involved in clinical trials. And if I miss some of them out, forgive me, it's a question of time. Pegylation, the application of polyethylene glycol in various sizes to factor VIII and IX molecules, is one that's been widely used by companies to try and extend the half-life of products. And indeed, pegylation is now a standard technique. It's already applied to numerous other medications, including therapies for gout and even hepatitis C, for instance. And pegylation simply involves smothering, if you like, although it's usually targeted, the molecule, the active molecule, with polyethylene glycol. And this protects it from degradation. So to take one study that I was involved with, this is the factor IX study from Novo Nordisk, but I want to emphasize that pegylation is being used by other companies, for instance, Baxter. But in the case of factor IX, what happened was that factor IX has got this activation peptide which is clipped out once the molecule is activated. And the polyethylene glycol is very specifically attached to asparagine residues in this activation peptide, so it doesn't interfere with the circulating molecule. Once the factor IX molecule is activated, this bit gets clipped out. And the point is, the early study yielded very fantastic results, a fivefold prolongation of the half-life. Remember that factor IX already has a longer half-life than factor VIII, so going from a half-life of some 18 hours up to 93 hours really was a very significant extension. And just putting that in graphical terms, here we've got on the left-hand side the decay curves for both plasma-derived and recombinant, and you can see a very clear difference when you look at the pegylated factor IX. So easily you can achieve with a single dose of factor IX, you'll get a trough level of 2% even after 1 week. And that says much the same thing. Now, polyethylene glycol pegylation of factor VIII has also been reported, and I'd draw your attention to a recent publication in the Journal of Thrombosis and Hemostasis. Again, it's from the Novo Nordisk group with their factor VIII molecule, and again, it's very much the same principle, that in this case, the polyethylene glycol is attached to part of the B domain, which again is removed when the factor VIII molecule is removed. And this publication from earlier in the year, and I'm going to show you the graph in a moment, shows that the half-life extension of factor VIII was some 1.6-fold. So a reasonable extension, but certainly far short of that seen with the factor IX. And as you'll see, that is a common problem. So in the publication that came out earlier this year from 2013, on the top here, we've got the factor VIII decay curves in red for a recombinant factor VIII product, and here a slight extension of the half-life for the pegylated factor VIII, and showing if in this logarithmic curve here with various doses from 25 up to 75 units per kilogram, that it is possible to achieve, even at 96 hours after one of these doses, a factor VIII trough level of 1%. Now, an interesting study that was published earlier this year suggests that perhaps there may be another advantage to pegylation. In this study published in, I think, June of this year in Blood, what was shown was that actually if you pegylate factor VIII, it is taken up less avidly into dendritic cells, which are important immune cells. They are the cells in the body which, if you like, initiate, they present the factor VIII to the immune cells. What this is actually showing on the left here is the binding to dendritic cells of either conventional factor VIII here, or the pegylated factor VIII. And on the right, you see, not just binding, this is internalization, actually the factor VIII being taken up into the dendritic cells, and again, you see far more of the conventional factor VIII is taken up. In fact, there's a 7-fold difference in binding to the dendritic cells. And these authors speculate, and that's why I've actually quoted very clearly here, that this leads us to at least hypothesize that perhaps this reduced endocytosis may translate into a clinical benefit, namely a reduction in inhibitors. And certainly, if this does work out in clinical practice, this would be an enormous additional advantage. So I'd just like you to be aware of this potential hypothesis that has been put forward. Does pegylation of factor VIII reduce the risk of inhibitor development because of the binding and internalization with the dendritic cells? Now, you can also extend half-lives of molecules by piggybacking them onto immunoglobulins, and this has already been done with certain molecules such as etanercept, for instance, and also L-trombopag, which is a thrombopoietin analog. And this exploits the natural recycling that takes place of immunoglobulin antibodies, and it's a technique which has been taken forward in the field of haemophilia by Biogen, IDEC, and Sobi. And what this chart shows is why immunoglobulin immunoglobulin molecules have such a long half-life in the body? What happens is they're taken up from the bloodstream into these little vesicles. And if the immunoglobulin, which is this little purple Y-shaped molecule here, binds to these receptors called the FcRn receptors, this protects them from degradation in the acidic environment in the lysosomes here. And so molecules that are not bound to the FcRn receptor are destroyed, but those that do bind to the FcRn receptor are protected. And then, a bit like these screensavers you get sometimes on Windows that bounce about your window, bounce around your screen, what happens is these vesicles bounce about the cell, and sometimes as they reach the border of the endothelium, they can be released. And as in the physiological pH situation here, the binding between immunoglobulin and the FcRn receptor is disrupted again, and you get a recycling. And again, this has been done with factor IX. This is just showing a factor IX attached to part of the immunoglobulin molecule. You can incidentally bind one or two factor IX molecules. In fact, it's very clear that binding it in a monomeric form yields better results for reasons that are still not absolutely clear. And taking a publication from the Biogen IDEC and SOBI study that was published last year, this is Amy Shapiro's paper, looking at the original pharmacokinetics in an early clinical study, you can see a very good prolongation of the half-life reported for factor IX in this study. So a very good result. This is what's called a Monte Carlo simulation taken from the same publication. And what it's showing is with 3 dosing regimens, either 20 units per kilogram once a week, 40 units per kilogram every 10 days, or 100 units per kilogram every 14 days, it's showing you in blue the sort of levels that you might get. In red, we've got a 1% trough level, and here in green, we've got a 3% trough level. So with these dosage regimens, we can begin to achieve the sort of trough levels that Mark Skinner was talking about in his plenary, which I quoted earlier. Now, Fc fusion molecules have, therefore, if you look at the factor VIII study, that's also been published. The one I showed you earlier referred to the factor IX study, which is known as the B-long study. In the A-long study, some prolongation of the factor VIII is seen, but again, by contrast with factor IX, somewhat disappointing at around 1.7-fold. I'd also point out there has been some speculation about these products. Again, if you read this review article, it refers to these earlier publications. The fact is that having a factor VIII, or for that matter, factor IX molecule bound to immunoglobulin raises an intriguing question. Do these molecules, for instance, cross the placenta? This might have, if it turns out to be true, important implications, for instance, for managing the pregnancy in female carriers. The fact that these immunoglobulin molecules are carrying factor VIII and factor IX, does that also help to, if not just induce immune tolerance? Again, possibly there is the theoretical possibility of reducing inhibitor development in the first place. So again, an intriguing theoretical possibility that modifying the half-life of molecules in this way actually brings added benefits as well, but this is purely speculative. This is looking at the A-long study, and again, an interesting point that comes out here. What this is looking at the top here is the half-life of the factor VIII activity. But what's interesting is that there's a definite link with the von Willebrand factor level, so that patients who've got high von Willebrand factor levels appear to have a significantly longer half-life. So look what we've got over here. So we've got, what this is showing is a correlation on this side here, von Willebrand factor antigen and the half-life. This is showing for normal recombinant factor VIII, so conventional factor VIII, this has already been shown before, that the higher the von Willebrand antigen level in a patient, the longer the half-life. But that effect is enhanced with these molecules, with the increased half-life molecules. And the half-life is increased, and at the same time, the clearance goes down. And we know, for instance, that von Willebrand antigen level is linked to blood group. And so in this way, perhaps we can identify those patients who might benefit most from having one of these molecules as therapy, because they will get even better prolongation of their half-life than those with a low von Willebrand factor level. And then the next method that's been used has been adopted by CSL Behring, and in a technique that they regard as the natural alternative to polyethylene glycol. Why? Because what's being used is a recombinant albumin sequence, which is used to carry the appropriate coagulation molecule, and they've used this with factor IX and also with factor VIIa, so activated factor VII. So what you do is take your recombinant coagulation molecule, link it with a small sequence here. The purpose of this short linker sequence is to avoid steric hindrance, that is, interference with the functional activity of this recombinant protein by the recombinant albumin. And here you've got the sequence here. And this is just showing in slightly larger detail the fact that it's been done with both factor IX by CSL Behring as well as their factor VIIa molecule. And the data on the factor IX have already been published by Elena Sant'Agostino, who led on this. It was published in 2012. And again, very good extension of the half-life of the factor IX molecule. The studies with factor VIIa proceed. They're in a much earlier stage, although there's some evidence from animal models, which I'm not showing here, that there is a some six-fold increase in the half-life of VIIa would be anticipated using this technology, although there is a significant problem with steric hindrance, even with that linker section, so much so that you'll be aware the typical dose for Novo 7 in therapy is, clinical use is 90 micrograms per kilogram. Here they're having to start with doses as high as 1,000 micrograms per kilogram to get the same sort of biological effect. But that study is in a much earlier phase. And then I want to talk about a study of CSL Behring's with their factor VIII molecule. I'm actually chairman of the Data Safety Monitoring Group for this study, so there's a limit to what I can say about it. But just to remind you that the factor VIII molecule is a very long molecule, but in the plasma it circulates as this chain here of 2,332 amino acids. Once it's been activated, it's divided into two parts of the molecule. You've got the long and the short, the heavy, and you've got the heavy and the light chains, which are rather tenuously linked. And then the factor VIII molecule is broken up in two ways. Firstly, this rather tenuous link between the heavy and the light chains is disrupted. And then, of course, activated protein C also cleaves very specific points within the heavy chain as well. Now, what CSL Behring have done is effectively weld together the heavy and the light chain by introducing molecules that link the heavy and light chains covalently. And at the same time, incidentally, the binding site for von Willebrand factor is also modified to actually increase affinity for von Willebrand factor. There is a clinical trial underway, and very preliminary data suggest a T half-life extension of around 1.6-fold with this molecule from CSL Behring. And you'll see that a recurrent theme with these products is that it's much easier to extend the half-life of factor IX compared to factor VIII. And this is probably because of the role of von Willebrand factor. Von Willebrand factor is, of course, the big brother. It's the large molecule that carries factor VIII in the circulation. And therefore, wherever it goes, so too does the factor VIII that is bound to it. So even if you modify the level of the activity of the factor VIII, if it's stuck by it just has to go where the von Willebrand factor molecule goes. And this hypothesis that it is attributed to the difference in von Willebrand factor is borne out by experimental animals in mice. Where if you take mice with knockout sequences, both for the knockout the factor VIII and the von Willebrand factor genes, in fact, you can extend the half-life of recombinant factor VIII bound to immunoglobulin some fivefold. And this observation has also been seen with pegylated factor VIII. Talking of, I want to just say something about inhibitor patients as well, because just to remind you that porcine factor VIII was a product that was used to treat patients with inhibitors and was withdrawn in 1996 due to concerns over pathogen safety. I want to remind you that a recombinant version of this is now under development now by Baxter and being taken forward in clinical trials, and we're involved, for instance, in a clinical trial with acquired haemophilia. The point being that the pig or porcine factor VIII sequence is sufficiently similar to human factor VIII to work like human factor VIII, but at the same time it's sufficiently different that it is not interfered with by the antibodies. It's not bound as avidly by antibodies. So this is an exciting potential therapy as well. Now, I said I wasn't just talking about long-acting products. I also want to introduce the concept which is being developed by two companies, Novo Nordisk and Baxter, of inhibiting an important protein in the blood, which is tissue factor pathway inhibitor. I'll show you graphically in the next slide, but the role of tissue factor pathway inhibitor is, if you like, to serve as a natural anticoagulant and block the process of clotting. Let me show you this graphically. What happens when you have vessel injury? The first thing that happens is that tissue factor is released, and binds to factor VII in the circulation to cause the formation of activated factor VII, which drives the thrombotic process, drives the formation of thrombin. But opposing that is the effect of this natural, because in all natural systems there is a system of balanced activity, and TFPI, tissue factor pathway inhibitor, is, if you like, a natural anticoagulant that blocks this complex of tissue factor and 7A. So opposing the thrombotic drive. So is it possible to block the effect of TFPI? The answer to that is yes. Does it have any therapeutic benefit? Again, the answer to that seems to be yes. And this is theoretically of interest because no one's suggesting that it's going to be a treatment necessarily for acute bleeds, but there is at least some rationale that using a TFPI inhibitor could perhaps confer protection from recurrent and spontaneous bleeds in patients with haemophilia A and B, as well as those with inhibitors, for instance. And indeed, just to show you two things. Firstly, Baxter have been doing some work with an aptamer, and this is the publication that I refer to here. What Novo Nordisk have done is to develop a monoclonal antibody, and this name, concizumab, has now been given to this molecule. So concizumab is an antibody that's directed to a very specific part of the TFPI molecule. For the technically minded, it's the Kunitz 2 domain of TFPI. This is a monoclonal antibody which is made in a formulation that can be injected subcutaneously with a pen, a bit like injecting insulin under the skin. And again, to look at a publication that was from last year, what this group with this particular molecule, which is now called concizumab, as I said, have done in a mouse model, have shown, in rabbit, I'm sorry, is they've taken a standard test which is called the cuticle bleeding test. In other words, you take a rabbit and you cut the cuticle of the nails and observe the bleeding. And I think it's best if I show you the next slide, which shows it graphically. So here we've got the level of the antibody in the blood and the time over days. This is the blood loss in a haemophilic rabbit, and you can see it's quite significant. If, on the other hand, you take just a baseline without having this monoclonal antibody, if then you give this monoclonal antibody, you will see that there is a very significant reduction in the blood loss after clipping the cuticles for up to 7 days, and that parallels or is associated with a sustained level of the monoclonal antibody in the blood. As the level falls off, then this protection falls off. So again, some suggestion from animal models that this isn't just theoretical, it may indeed prevent bleeding. And finally, I want to mention a study which is being taken forward by Chugai, and this is a Japanese company and built on from a publication at the end of last year in Nature Medicine. And what they've done is they've built a bispecific monoclonal antibody which effectively mimics the cofactor activity of factor VIII, and it's not affected by the presence of inhibitors. Again, it'll become clear in the next slide, which I'm going to show you. So you've got to remember that factor VIII is basically an inert scaffold around which two important proteins assemble. So what we've got on the left-hand side is effectively the membrane of a platelet. And on this phospholipid surface assemble two molecules, factor IX, which is a true enzyme, and factor X, and they assemble around factor VIII, which is actually not an enzymic protein. It is an essentially inert scaffold. And what Chugai have done is to produce this bispecific antibody which holds rigidly in place two molecules, activated factor IX and factor X. So even without any factor VIII activity there, you can generate factor Xa at levels that are seen in patients with 1 to 10% of factor VIII in vitro. So this has been done in primates and cynomolgus monkeys in a model of acquired haemophilia, and now Chugai are taking this forward in clinical trials. So this is my last slide, and the next talk is about gene therapy, and I have every faith in gene therapy, which will ultimately offer a cure for haemophilia, but longer-acting factor concentrates are clearly a much more realistic goal. And I've talked about the main ways in which the activity of factor VIII and IX can be extended, namely pegylation, binding to immunoglobulin molecules, or genetic fusion with albumin. And I've also talked about inhibition of tissue factor pathway inhibitor, which may also be useful as adjunctive therapy for patients with haemophilia A and B, as well as those with inhibitors. So I'll finish there within my time, as always. Thanks very much.